Welcome back to NCLEX-RN, your go-to channel for NCLEX success. Today, we're tackling labour and delivery emergencies, one of the most critical topics on the exam. Let's dive into 30 high-yield questions with detailed rationales for both correct and incorrect answers. Ready? Let's go. Question 1. Shoulder dystocia. A labouring patient at 39 weeks gestation delivers the fetal head, but the shoulders remain stuck. What is the priority nursing intervention? A. Apply fundal pressure. B. Perform McRoberts manoeuvre. C. Attempt a forceps delivery. D. Request an emergency C-section. Correct answer: B. Perform McRoberts manoeuvre. Rationale. Shoulder dystocia happens when the baby's shoulders get trapped behind the pubic bone. The McRoberts manoeuvre is the first-line intervention, involving hyperflexing the mother's thighs towards her abdomen to widen the pelvis and free the shoulders. Incorrect answers. A. Apply fundal pressure. Dangerous. This worsens the impaction and increases the risk of brachial plexus injury or clavicle fracture. C. Attempt a forceps delivery. Forceps are not used for shoulder dystocia since the head is already delivered. D. Request an emergency C-section. A C-section is not possible once the head is out. The focus should be on manoeuvres to deliver the shoulders. Deep dive. Shoulder dystocia. This is a true emergency that can lead to fetal hypoxia if not resolved quickly. Other interventions include suprapubic pressure, the Gaskin manoeuvre hands and knees position, or the Woods corkscrew manoeuvre if McRoberts fails. Question 2. Prolapsed umbilical cord. A nurse notes a prolapsed umbilical cord in a labouring patient at 38 weeks. What is the first action? A. Place the patient in knee-chest position. B. Administer oxygen at 10 litres per minute. C. Prepare for an emergency C-section. D. Check fetal heart rate. Correct answer. A. Place the patient in knee-chest position. Rationale. The priority is to relieve cord compression. The knee-chest or Trendelenburg position uses gravity to shift the fetus away from the cord and restore blood flow. Incorrect answers. B. Administer oxygen. While oxygen can help fetal perfusion, it does not relieve pressure on the cord. C. Prepare for an emergency. C-section. While a C-section is needed, the immediate action should be to relieve pressure before surgical prep. D. Check fetal heart rate. This is important, but not the priority. We already know the cord is prolapsed. Intervene first, assess later. Deep dive. Prolapsed cord. A prolapsed cord cuts off oxygen to the baby, leading to bradycardia and fetal distress. Nurses should use a sterile gloved hand to lift the presenting part off the cord and maintain this position until delivery. Question 3. Uterine rupture. A patient attempting a VBAC, vaginal birth after caesarean, suddenly complains of severe abdominal pain, loss of contractions, and fetal bradycardia. What is the most likely cause? A. Placental abruption. B. Uterine rupture. C. Cord prolapse. D. Amniotic fluid embolism. Correct answer: B. Uterine rupture. Rationale. Uterine rupture occurs when the uterine wall tears, often along a previous C-section scar. Symptoms include sudden pain, loss of contractions, fetal distress, and possible maternal hypovolemia. Incorrect answers. A. Placental abruption. While it also causes abdominal pain, uterine rupture leads to a loss of contractions, while abruption causes hypertonic contractions. C. Cord prolapse. Would present with visible cord and fetal bradycardia, but not severe maternal pain. D. Amniotic fluid embolism. Presents with respiratory distress, hypertension, and DIC, not loss of contractions. Deep dive. Uterine rupture. This is life-threatening. Risk factors include previous C-section, trauma, excessive oxytocin use, or grand multiparity, many pregnancies. Immediate C-section and maternal resuscitation are crucial. Question 4. Amniotic fluid embolism, AFE. A labouring patient suddenly develops hypertension, respiratory distress, and cyanosis. What is the priority action? A. Administer oxygen and call a rapid response. B. Perform CPR. C. Give IV fluids. D. Intubate the patient immediately. Correct answer: A. Administer oxygen and call a rapid response. Rationale: amniotic fluid embolism, AFE, occurs when amniotic fluid enters maternal circulation, triggering anaphylactic shock. Oxygenation and emergency response are critical. Incorrect answers: B. Perform CPR. While AFE can lead to cardiac arrest, oxygen and supportive care should come first. C. Give IV fluids. This helps maintain BP but does not address the respiratory failure. D. Intubate the patient immediately. While necessary in severe cases, oxygenation and calling for HELLP take priority. Deep dive: amniotic fluid embolism. This is a rare but deadly obstetric emergency with up to 80% maternal mortality. Symptoms include sudden hypoxia, hypertension, DIC, and cardiac arrest. Treatment includes oxygen, fluids, vasopressors, and ICU care. Question 5. Postpartum hemorrhage, PPH. A patient experiences heavy vaginal bleeding, more than 1,000 milliliters, within 24 hours after birth. What is the first nursing action? A. Massage the fundus. B. Administer oxytocin. C. Call the provider. D. Start a blood transfusion. Correct answer: A. Massage the fundus. Rationale: the most common cause of PPH is uterine atony, a soft, boggy uterus. Fundal massage stimulates contractions and reduces bleeding. Incorrect answers: B. Administer oxytocin. Effective, but only after fundal massage. C. Call the provider. Yes, but intervene first. D. Start a blood transfusion. Needed for severe cases, but massage and medications come first. Deep dive: postpartum hemorrhage. PPH is the leading cause of maternal death. Risk factors include prolonged labour, multiple gestation, and uterine overdistension. Treatment involves massage, oxytocin, methylagonovine, misoprostol, or surgery if needed. Question 6. Placental abruption. A patient at 35 weeks gestation presents with severe abdominal pain, dark red vaginal bleeding, and a rigid uterus. What is the likely diagnosis? A. Placenta, Previa. B. Uterine rupture. C. Placental abruption. D. Cord prolapse. Correct answer: C. Placental abruption. Rationale: placental abruption occurs when the placenta detaches from the uterine wall prematurely, cutting off fetal oxygen. Symptoms include painful, dark red bleeding and a firm uterus. Incorrect answers: A. Placenta, Previa, causes painless, bright red bleeding, not severe pain. B. Uterine rupture, causes sudden pain, fetal distress, and loss of contractions. D. Cord prolapse, involves a visible, protruding umbilical cord, not bleeding. Deep dive: placental abruption. Risk factors include hypertension, trauma, smoking, and cocaine use. This is a medical emergency requiring immediate delivery if fetal distress is present. Question 7. Eclampsia. A pregnant patient with preeclampsia suddenly experiences a tonic-clonic seizure. What is the priority nursing intervention? A. Administer IV magnesium sulfate. B. Turn the patient to the left side. C. Check fetal heart rate. D. Give labetalol IV. Correct. Answer: B. Turn the patient to the left side. Rationale: the first priority is to prevent aspiration and airway obstruction by turning the patient laterally. Incorrect answers. A. Administer Magnesium sulfate. This prevents further seizures, but airway protection comes first. C. Check fetal heart rate. Important, but not the first action. D. Give labetalol IV, used for hypertension, but does not stop the seizure. Deep dive. Eclampsia. This is a severe complication of preeclampsia. Patients need magnesium sulfate, antihypertensives, and immediate delivery. Question 8. Uterine inversion. A nurse notices the uterus has prolapsed outside the vagina after delivery. What's the first nursing action? A. Attempt to manually replace the uterus. B. Administer oxytocin. C. Place the patient in Trendelenburg position. D. Call for immediate surgical intervention. Correct answer, C. Place the patient in Trendelenburg position. Rationale: Trendelenburg position helps keep the uterus in place and reduces further prolapse until manual replacement is attempted. Incorrect answers. A. Attempt to manually replace the uterus. This is done by the provider, not the nurse. B. Administer oxytocin, contraindicated initially as it can worsen inversion. D. Call for immediate surgical intervention. Surgery is a last resort. Manual replacement is attempted first. Deep dive. Uterine inversion. This rare emergency occurs when excessive cord traction is applied. Treatment includes fluid resuscitation, uterine replacement, and uterotonics after repositioning. Question 9. Late decelerations. A labouring patient is on continuous fetal monitoring. The nurse notices late decelerations on the fetal heart tracing. What is the priority intervention? A. Increase IV fluids. B. Turn the patient to the left side. C. Apply an oxygen mask. D. Stop oxytocin infusion. Correct. Answer. B. Turn the patient to the left side. Rationale: late decelerations occur due to uteroplacental insufficiency, poor oxygen delivery to the fetus. Turning the patient to the left side improves blood flow. Incorrect answers. A. Increase IV fluids. Helps improve circulation, but is not the first intervention. C. Apply an oxygen mask. Oxygen can help, but only after repositioning. D. Stop oxytocin infusion. Stopping oxytocin can reduce contractions, but repositioning is still the first priority. Deep dive. Late decelerations. Late decels indicate fetal distress. If turning doesn't work, interventions include oxygen, IV fluids, stopping oxytocin, and preparing for delivery. Question 10. Magnesium toxicity. A patient receiving magnesium sulfate for preeclampsia has absent deep tendon reflexes and a respiratory rate of 8 breaths per minute. What should the nurse do first? A. Stop the magnesium infusion. B. Administer calcium gluconate. C. Prepare for intubation. D. Check magnesium levels. Correct answer. A. Stop the magnesium infusion. Rationale: magnesium toxicity causes depressed CNS function, leading to respiratory depression. The first step is to stop the infusion to prevent further toxicity. Incorrect answers. B. Administer calcium gluconate. This is the antidote, but is given after stopping magnesium. C. Prepare for intubation, not necessary unless severe respiratory failure occurs. D. Check magnesium levels. Important, but not the immediate priority. Deep dive. Magnesium toxicity. Symptoms include hyperreflexia, respiratory depression, and cardiac arrest. Always monitor DTRS, deep tendon reflexes, urine output, and respiratory rates. Question 11. Umbilical cord compression. A nurse notes variable decelerations on the fetal heart tracing. What is the best intervention? A. Perform an amnioinfusion. B. Turn the patient to the left side. C. Apply oxygen. D. Encourage deep breathing. Correct answer. B. Turn the patient to the left side. Rationale: Variable decelerations result from cord compression, which can be relieved by changing maternal position. Incorrect answers. A. Perform an amnio infusion, used in severe cases, but positioning is the first step. C. Apply oxygen, not always necessary unless severe distress occurs. D. Encourage deep breathing. This doesn't address cord compression. Deep dive, variable decelerations. If repositioning doesn't work, additional interventions include IV fluids, oxygen, or amnio infusion to reduce cord compression. Question 12. Uterine hyperstimulation. A patient on oxytocin is having contractions every 90 seconds, lasting 100 seconds. What should the nurse do first? A. Continue monitoring. B. Stop the oxytocin infusion. C. Administer terbutaline. D. Increase IV fluids. Correct. Answer. B. Stop the oxytocin infusion. Rationale: uterine hyperstimulation, tachysystole, reduces fetal oxygenation. The first step is stopping oxytocin to reduce contraction frequency. Incorrect answers: A. Continue monitoring. Dangerous. The fetus is at risk of hypoxia. C. Administer terbutaline, a tocolytic used if stopping oxytocin doesn't work. D. Increase IV fluids, helps but not the first priority. Deep dive: uterine tachysystole. Defined as more than 5 contractions in 10 minutes, treatment includes stopping oxytocin, repositioning, and oxygen if needed. Question 13. Placenta Previa. A pregnant patient at 30 weeks gestation presents with painless, bright red vaginal bleeding. What is the priority action? A. Perform a vaginal exam. B. Place the patient in Trendelenburg position. C. Prepare for emergency C-section. D. Monitor bleeding and avoid vaginal exams. Correct answer: D. Monitor bleeding and avoid vaginal exams. Rationale: placenta previa is when the placenta covers the cervix, leading to painless, bright red bleeding. Vaginal exams are contraindicated as they can cause severe hemorrhage. Incorrect answers. A. Perform a vaginal exam. Never do this. It can trigger massive bleeding. B. Place the patient in Trendelenburg position. Not helpful for placenta previa. C. Prepare for emergency C-section. C-section is often needed, but not immediately unless bleeding is severe. Deep dive: placenta previa. Risk factors include multiple pregnancies, smoking, and prior C-sections. Patients may need hospitalization and planned C-section at 36 to 37 weeks. Question 14. Chorioamnionitis. A patient in labor has a fever of 102 degrees Fahrenheit, fetal tachycardia, and foul-smelling amniotic fluid. What is the best initial intervention? A. Administer 4th antibiotics. B. Perform an amniotomy. C. Encourage ambulation. D. Apply a fetal scalp electrode. Correct answer: A. Administer IV antibiotics. Rationale: chorioamnionitis is a bacterial infection of the amniotic fluid. The priority is 4th antibiotic therapy to prevent sepsis. Incorrect answers: B. Perform an amniotomy. Never. This could worsen infection. C. Encourage ambulation, contraindicated due to infection risks. D. Apply a fetal scalp electrode, not appropriate in infection cases. Deep dive: chorioamnionitis. Risk factors include prolonged rupture of membranes. Treatment includes IV antibiotics and early delivery if infection is severe. Question 15. HELLP syndrome. A pregnant patient with preeclampsia presents with right upper quadrant pain, severe hypertension, and low platelets. What is the most appropriate intervention? A. Administer IV magnesium sulfate. B. Prepare for immediate delivery. C. Give 4 antihypertensives. D. Start a blood transfusion. Correct answer: B. Prepare for immediate delivery. Rationale: HELLP syndrome. Hemolysis, elevated liver enzymes, low platelets. is a severe complication of preeclampsia. Delivery is the only cure. Incorrect answers. A. Administer IV magnesium sulfate. Prevents seizures, but does not treat HELLP. C. Give IV antihypertensives. Needed, but not the priority. D. Start a blood transfusion. Not first line unless severe hemorrhage occurs. Deep dive. HELLP syndrome. This can cause DIC, disseminated intravascular coagulation. Immediate delivery is needed to save both mother and baby. Question 16. Uterine atony. A postpartum patient has a boggy uterus and heavy vaginal bleeding. What is the first nursing intervention? A. Massage the fundus. B. Start a blood transfusion. C. Administer methylogonavine. D. Prepare for hysterectomy. Correct. Answer. A. Massage the fundus. Rationale. Uterine atony, failure of the uterus to contract after birth, is the leading cause of postpartum hemorrhage. Fundal massage stimulates contraction. Incorrect answers. B. Start a blood transfusion. Only necessary if severe hemorrhage occurs. C. Administer methylogonavine. Used after massage fails. D. Prepare for hysterectomy. Only done if bleeding is uncontrollable. Deep dive. Uterine atony. Risk factors include multiple gestation, prolonged labour, and high-dose oxytocin. Treatment includes massage, oxytocin, and possibly surgery. Question 17. Perineal hematoma. A postpartum patient reports severe perineal pain and swelling, but there is minimal vaginal bleeding. What should the nurse assess for? A. Vaginal laceration. B. Perineal hematoma. C. Uterine rupture. D. Bladder distension. Correct answer. B. Perineal hematoma. Rationale. A perineal hematoma is a collection of blood in soft tissue. It can cause severe pain but little visible bleeding. Incorrect answers. A. Vaginal laceration would cause visible bright red bleeding. C. Uterine rupture causes abdominal pain and fetal distress, not perineal pain. D. Bladder distension can cause pain but not swelling in the perineum. Deep dive. Perineal hematomas. Risk factors include instrument-assisted delivery and prolonged pushing. Small hematomas may resolve on their own, but large ones require surgical drainage. Question 18. Maternal hypertension after epidural. A pregnant patient at 39 weeks gestation receives an epidural, then develops hypertension and fetal bradycardia. What is the first nursing action? A. Increase IV fluids. B. Turn the patient to the left side. C. Stop the epidural infusion. D. Prepare for an emergency C-section. Correct answer. B. Turn the patient to the left side. Rationale. Epidurals can cause hypertension due to vasodilation, reducing placental perfusion. Turning the patient leftward improves blood flow to the fetus. Incorrect answers. A. Increase IV fluids. Helps, but positioning is first. C. Stop the epidural infusion. Not necessary unless BP remains low. D. Prepare for an emergency C-section. Only if interventions fail. Deep dive. Epidural hypertension. Prevent it by preloading with IV fluids before epidural placement. If severe, use vasopressors like ephedrine. Question 19. Preterm labour management. A patient at 32 weeks gestation is experiencing regular contractions and cervical dilation. What medication should the nurse prepare to administer? A. Oxytocin. B. Terbutaline. C. Methylogonavine. D. Carbaprost. Correct answer. B. Terbutaline. Rationale. Terbutaline is a tocolytic that relaxes the uterus and delays preterm labour. Incorrect answers. A. Oxytocin would increase contractions. C. Methylogonavine, used for postpartum hemorrhage, not preterm labour. D. Carbaprost, used to manage postpartum hemorrhage. Deep dive. Preterm labour. Tocolytics like magnesium sulfate, nifedipine and indomethacin may also be used. Betamethasone is given to mature fetal lungs. Question 20. DIC, disseminated intravascular coagulation. A postpartum patient is bleeding from IV sites and mucous membranes with low fibrinogen and platelets. What is the priority intervention? A. Administer IV heparin. B. Start fluid resuscitation and blood products. C. Massage the uterus. D. Place the patient in Trendelenburg. Correct answer. B. Start fluid resuscitation and blood products. Rationale. DIC is a life-threatening clotting disorder leading to widespread bleeding. Treatment includes IV fluids, blood products and oxygen support. Incorrect answers. A. Administer IV heparin. Not appropriate in postpartum DIC. C. Massage the uterus. Only useful if uterine atony is the cause. D. Place in Trendelenburg. Does not address the underlying issue. Deep dive. DIC. Common causes include placental abruption, HELLP syndrome, and amniotic fluid embolism. DIC is a medical emergency. Question 21. Hypotonic uterine contractions. A labouring patient receiving oxytocin has contractions occurring every 1 minute, lasting 100 seconds. What is the first nursing action? A. Increase IV fluids. B. Discontinue oxytocin. C. Administer terbutaline. D. Apply oxygen. Correct. Answer. B. Discontinue oxytocin. Rationale. Uterine tachysystole, hyperstimulation, reduces fetal oxygenation. Stopping oxytocin is the first step. Incorrect answers. A. Increase IV fluids. Helps, but not the priority. C. Administer terbutaline. Used if stopping oxytocin doesn't work. D. Apply oxygen. Helps, but turning off oxytocin comes first. Deep dive. Uterine tachysystole. Defined as more than 5 contractions in 10 minutes. Treatment includes stopping oxytocin, repositioning and oxygen if needed. Question 22. Fetal tachycardia. A nurse is assessing fetal heart tones and notes a heart rate of 180 beats per minute. What is the most likely cause? A. Maternal fever. B. Cord prolapse. C. Placental abruption. D. Uterine rupture. Correct answer. A. Maternal fever. Rationale. Fetal tachycardia greater than 160 beats per minute is commonly caused by maternal fever or infection, chorioamnionitis. Other causes include fetal hypoxia, dehydration, and anemia. Incorrect answers. B. Cord prolapse. Would cause variable decelerations, not tachycardia. C. Placental abruption. Causes late decelerations and fetal distress. D. Uterine rupture. Leads to bradycardia, not tachycardia. Deep dive. Fetal tachycardia. If fetal tachycardia is persistent greater than 10 minutes, interventions include hydration, oxygen, and treating maternal fever or infection. Question 23. Umbilical cord prolapse. A nurse notices a prolapsed umbilical cord on vaginal examination. What is the priority action? A. Place the patient in knee-chest position. B. Administer oxygen. C. Perform an immediate C-section. D. Check fetal heart tones. Correct answer. A. Place the patient in knee-chest position. Rationale. The priority is to relieve pressure on the cord. The knee-chest or Trendelenburg position uses gravity to shift the baby away from the cord, restoring blood flow. Incorrect answers. B. Administer oxygen. Helps, but not the first priority. C. Perform an immediate C-section. C-section is needed, but first we relieve cord pressure. D. Check fetal heart tones. We already know there's an emergency. Act first. Deep dive. Umbilical cord prolapse. If the cord is visible, the nurse should use a sterile gloved hand to lift the presenting part off the cord until the provider arrives for an emergency C-section. Question 24. Supine hypertension. A 37-week pregnant patient is lying flat and suddenly reports dizziness and nausea. What should the nurse do first? A. Increase IV fluids. B. Place the patient in the left lateral position. C. Check fetal heart tones. D. Administer oxygen. Correct answer. B. Place the patient in the left lateral position. Rationale. Supine hypertensive syndrome occurs when the uterus compresses the inferior vena cava, reducing venous return and cardiac output. Incorrect answers. A. Increase IV fluids. Helps, but repositioning is first. C. Check fetal heart tones. Important, but intervene first. D. Administer oxygen. Helps, but positioning comes first. Deep dive. Supine hypertension. Symptoms include dizziness, nausea, and fetal decelerations. Prevention. Encourage side-lying positions, especially after 20 weeks. Question 25. Post-term pregnancy risks. A patient at 42 weeks gestation is admitted for labour induction. What is the greatest concern? A. Preterm labour. B. Placental insufficiency. C. Uterine atony. D. Shoulder dystocia. Correct answer. B. Placental insufficiency. Rationale. Post-term pregnancies greater than 42 weeks increase the risk of placental aging, leading to reduced oxygen and nutrient supply to the fetus. Incorrect answers. A. Preterm labour. Wrong. This is a post-term pregnancy. C. Uterine atony. More common after delivery, not during labour. D. Shoulder dystocia. Possible, but not the primary concern. Deep dive. Post-term pregnancy. Risks include late decelerations, meconium-stained fluid, and oligohydramnios. Induction or C-section is often necessary. Question 26. Persistent postpartum bleeding. A postpartum patient has a firm midline uterus but continues to have heavy vaginal bleeding. What should the nurse suspect? A. Uterine atony. B. Retained placenta. C. Cervical or vaginal lacerations. D. Disseminated intravascular coagulation, DIC. Correct answer. C. Cervical or vaginal lacerations. Rationale. If the uterus is firm but bleeding persists, the cause is likely lacerations of the cervix or vaginal walls. Incorrect answers. A. Uterine atony. Would cause a boggy, soft uterus. B. Retained placenta. Would cause prolonged bleeding, but with a boggy uterus. D. DIC. Leads to widespread bleeding from IV sites, not just vaginal bleeding. Deep dive. Vaginal lacerations. Risk factors include precipitous labour, forceps delivery, and macrosomia. Treatment. Surgical repair. Question 27. Most serious preeclampsia complication. Which complication of preeclampsia is most life-threatening? A. HELLP syndrome. B. Placental abruption. C. Eclampsia. D. Gestational hypertension. Correct answer. C. Eclampsia. Rationale. Eclampsia, seizures, is the most severe form of preeclampsia and can cause maternal stroke, coma, and fetal distress. Incorrect answers. A. HELLP syndrome. Serious, but not as immediately life-threatening as eclampsia. B. Placental abruption. Severe, but eclampsia leads to maternal collapse. D. Gestational hypertension. Mildest form, no seizures. Deep dive. Eclampsia. Treatment. Magnesium sulfate, IV antihypertensives, and immediate delivery. Question 28. Normal fetal heart rate. A nurse is monitoring a labouring patient using continuous fetal heart rate, FHR monitoring. Which FHR range is considered normal? A. 90 to 120 beats per minute. B. 110 to 160 BPM. C. 140 to 180 BPM. D. 160 to 200 BPM. Correct answer. B. 110 to 160 beats per minute. A normal fetal heart rate, FHR, range is 110 to 160 beats per minute by BPM. This indicates adequate oxygenation and perfusion. Incorrect answers. A. 90 to 120 beats per minute. Too low. FHR below 110 beats per minute for more than 10 minutes is considered fetal bradycardia. C. 140 to 180 beats per minute. While 140 beats per minute is normal, anything above 160 beats per minute for greater than 10 minutes indicates fetal tachycardia, possible infection, distress, or hypoxia. D. 160 to 200 beats per minute. Too high. Tachycardia over 160 beats per minute suggests maternal fever, chorioamnionitis, or fetal distress. Deep dive, FHR, monitoring and NCLEX tips. Nurses should monitor FHR for baseline rate, variability, and presence of decelerations. Persistent bradycardia or tachycardia requires intervention. Question 29. Magnesium, toxicity, antidote. A patient with preeclampsia is receiving a magnesium sulfate infusion for seizure prevention. The nurse notes absent deep tendon reflexes, DTRS, a respiratory rate of 8 breaths per minute, and drowsiness. What is the priority intervention? A. Stop the magnesium sulfate infusion. B. Administer calcium gluconate. C. Prepare for intubation. D. Increase IV fluids. Correct. Answer. B. Administer calcium gluconate. Rationale. Magnesium toxicity leads to respiratory depression, loss of deep tendon reflexes, DTRs, and cardiac arrhythmias. Calcium gluconate is the antidote and should be given immediately to reverse toxicity. Incorrect answers. A. Stop the magnesium sulfate infusion. Yes, but this is not the immediate priority. Calcium gluconate must be given first to counteract toxicity. C. Prepare for intubation, only needed if respiratory failure occurs. Give calcium gluconate first to restore respiratory function. D. Increase IV fluids, not effective for reversing toxicity. Deep dive. Magnesium toxicity signs and treatment. Magnesium toxicity can lead to cardiac arrest if untreated. The normal magnesium level is 4 to 7 milliequivalents per litre in pregnancy. Toxic levels greater than 9 milliequivalents per litre cause respiratory depression. Always keep calcium gluconate available when administering magnesium sulfate. Question 30. ROGAM administration. A nurse is caring for an Rh-negative pregnant patient at 28 weeks gestation. When should ROGAM be administered? A. At 28 weeks and within 72 hours postpartum, if the baby is Rh positive. B. Only during the first trimester. C. Only if the baby is Rh negative. D. At 20 weeks gestation and postpartum. Correct answer. A. At 28 weeks and within 72 hours postpartum if the baby is Rh positive. Rationale: ROGAM, Rh immune globulin, is given to Rh negative mothers to prevent Rh sensitization. First dose, at 28 weeks gestation. Second dose, within 72 hours postpartum. Only, if the baby is Rh positive. Incorrect answers. B. Only during the first trimester. Incorrect. ROGAM is given at 28 weeks and postpartum, not in early pregnancy. C. Only if the baby is Rh negative. Wrong. If the baby is Rh negative, a second ROGAM dose is not needed, but the 28-week dose is still given as a precaution. D. At 20 weeks, gestation, and postpartum. Incorrect timing. The correct time is 28 weeks and postpartum. Deep dive. Why is ROGAM important? Without ROGAM, an Rh negative mother can develop antibodies against future Rh positive pregnancies, leading to hemolytic disease of the newborn, HDN, jaundice, and fetal anemia. Always check the baby's blood type postpartum. That's it for today's NCLEX review. If you found this helpful, don't forget to like, comment, and subscribe for more high-yield nursing content. Let me know which topic you want next. See you in the next video, future RNs.